Welcome to this course series. I'll be talking about esophageal atresia and tracheoesophageal fistula. Esophageal atresia is a birth defect of the esophagus, where the esophagus has two separate segments, the upper and lower esophagus that do not connect. Babies born with this defect are unable to pass food from the mouth to the stomach. They can also present with difficulty in breathing and if associated with tracheoesophageal fistula. Epidemiology. This incidence is estimated to be approximately 1 in 4,000 live births. There is no sex predilection. The majority of cases are sporadic and non-syndromic. Familial cases account for less than 1% of all cases. Etiology. Etiological agent is related to the mental failure during early fetal growth. The reason for this failure is not fully understood. Isolated esophageal atresia and tracheoesophageal fistula is believed to occur due to the combination of multiple different factors. Such factors include genetic, environmental, and immunological factors. However, no specific contributing factors have been identified. Most cases of isolated esophageal atresia and tracheoesophageal fistula occur sporadically. The risk of occurrence in subsequent pregnancies is less than 1%. Non-isolated esophageal atresia and tracheoesophageal fistula refers to cases that occur along with other congenital defects, but without a known genetic defect. Heart defects are the most common associated congenital defect. Some individuals with non-isolated esophageal atresia and tracheoesophageal fistula have Bactal or Batal association. The term Bactal is an acronym. The TE stands for tracheoesophageal fistula and E esophageal atresia. Clinical features include difficulty in swallowing, difficulty in breathing, drooling of saliva, aspiration, if tracheoesophageal fistula is present, pneumonia, cough, cyanosis. Classification of esophageal atresia and tracheoesophageal fistula is divided into 5 subtypes. The type C is the most common. Other types affect less than 15% of individuals with esophageal atresia and tracheoesophageal fistula. The subtypes include type A, B, C, D, and E. Type A, only esophageal atresia is present. The esophagus is separated into 2, upper and lower. Both portions end in blind pouches, 8% of cases, also referred as pure esophageal atresia. Type B, the lower segment ends in a blind pouch. The upper segment communicates with the trachea via a tracheoesophageal fistula. Is rare. It accounts for about 2% of cases. Type C, the upper segment of esophagus ends in a blind pouch. The lower segment communicates with the trachea via tracheoesophageal fistula. This is the most common type of esophageal atresia and tracheoesophageal fistula that accounts for about 5% of cases. Type D, we have a tracheoesophageal fistula connecting both the upper and the lower segment of the blind ending of esophagus to the trachea. This is the rarest form of esophageal atresia and tracheoesophageal fistula. It occurs in less than 1% of cases. In type E, in this form, the esophagus is intact, connects the esophagus to the stomach. A tracheoesophageal fistula is present, connecting the esophagus and the trachea. This is also known as the H type. It occurs in 4% of cases. The images show the normal anatomy and then the variants of esophageal atresia and tracheoesophageal fistula. Diagnosis can be made before birth through the presence of a small